Those of us here at Colorado State University are proud to share with you this session of Endoscopy Talks. When you're looking for inspiring veterinary CE experiences, think CSU Vet CE. Nestled up against the Rocky Mountains in our new State of the Future facility, we invite you to experience what we call CE Elevated. We'd love to see you in one of our future on-site, online, or blended courses. Check us out at www.csuvetse.com. Now, please enjoy Endoscopy Talks. Well, hello everyone, and welcome to Endoscopy Talks. I'm Ross Palmer with Colorado State University, and I'd like to thank you for joining us on behalf of Colorado State University's Translational Medicine Institute. Today we're joined by Drs. Fiona Hollinshead and Greg Burns. Dr. Hollinshead received her veterinary degree from the University of Sydney, followed by a PhD in reproduction. She then completed a clinical residency in theriogenology at Cornell University and became a diplomat of the American College of Theriogenology. Fiona managed a rapidly growing small animal reproduction referral practice in New Zealand before joining the faculty at Colorado State University running the small animal theriogenology service. Dr. Greg Burns received his DVM from Colorado State University and worked as an associate veterinarian and then partner in a small animal practice here in Fort Collins, Colorado. He completed a mentorship residency and became a diplomat of the American College of Theriogenology. He has been an affiliate faculty member at Colorado State University since 2019 and a permanent faculty member since 2020, teaching small animal reproduction. So Dr. Hollinshead and Burns are going to discuss how to get started in transcervical insemination. So without any further delay, I'll turn the session over to them. Welcome.
Hello, thank you for joining us today, and thank you, Ross, for that introduction. That was fantastic. So we're going to talk about transcervical insemination today. So just a brief overview of this lecture. We'll just start with very quickly going over the history of transcervical insemination and where it was developed and how it started. And then I'll go over an anatomy review, which will basically cover the caudal reproductive tract of the bitch. Then Dr. Burns will talk about the equipment that we use for TCI, and then we'll both go into the transcervical insemination technique. And finally, at the end, we'll just touch on some other uses for the TCI scope that we use, including vaginoscopy, biopsy, cytology, and even the treatment of pyometra. So to start with the history of TCI, it was developed by Dr. Marion Wilson, who's from New Zealand way back in 1988. It was part of her master's thesis at Massey University. I was very lucky to get trained by Marion Wilson and took over her practice in 2006. And when I did, we used this, what she first developed is a modified human sister urethra scope, which is from Stores. And as you see, it's quite a short, thick scope with a external sheath on the outside. Has a straight bridge as well. And actually, to start with, Marion used to just look straight down the endoscope without a camera. Very soon after she developed the camera, as you all appreciate, made a massive difference with that attached. In 2006, Minitube, along with Stores, modified a human urethra scope, and that's now called the veterinary histoscope or the TCI endoscope, which we currently use today. And that's imaged here above the old, much shorter, much thicker sister urethra scope. Some of the bridges can be bent or straight, but mainly it's a very long, thin, very nice to use scope. So I'm just going to start by going a very basic anatomical overview of the reproductive tract. And mostly you'll be working the TCI with the caudal vagina, starting from down here, the vulval lips, through the vestibule, and then through the caudal vagina and all its folds, under a dorsal median fold, which you can see here on this gross anatomy, until we locate the cervix, which is located in this box here. And once we have the cervix, we have to orientate it and then catheterize it. For AI, the endoscope does not enter the uterus. It just goes up to the cervix, and that's where we catheterize things. So we'll discuss this more in the lecture as well, but it's really important to appreciate at this point that the length of the bitch's reproductive tract in relation to her body weight and size is extremely long. So to start with, the vagina is very, very long, even the cervical canal is very long, and the uterine horns are long. And these are some obstacles that we need to overcome when doing TCI. So just going to start with the caudal vagina, and it's critical to identify the caudal vagina anatomy. So obviously the vulval lips are parted, and that's where which is where the scope will go in. And then you find the clitoral fossa. It's really important to identify this landmark because you do not want to stick the scope in there because it'll cause intense pain and discomfort for the bitch, and you won't be able to TCI. She will not stand for it. Then go into the vestibule, and then you come up to the urethral papillar orifice. Now, if you wanted to catheterize it, it would be very difficult. But unfortunately, as you go over the pelvic brim with your scope, it actually can very easily slip into that urethral orifice, and then you can end up down into the bladder, which is not desirable. The next anatomical structure, which you should identify here, is the vestibulovaginal junction, also called the cingulum. And this acts as a sphincter, just like in all other species. It's not an impediment to TCI, but it is where a hymen can be, and that needs to be broken down and can cause discomfort. It's also important to palpate or look at, as this is where a lot of anatomical, pathological, often congenital developmental structures can be found, such as your vaginal strictures, septums, and other abnormalities. And then finally, you'll enter these spectacular vaginal folds. So now this is just an endoscopic view of the caudal vagina, and particularly the caudal vaginal folds at each stage of the estrus cycle. So firstly here, I'm going to show pro-estrus, and you can see a significant amount of bloody fluid, and that the vaginal wall is very pink and very soft and round and formed, and there's a very small lumen. It's not very easy to see through, see a lumen in the vagina here. Okay, then we'll move on to estrus, which is quite different. It's much paler and much more dehydrated. And as you can see, the lumen is a lot larger here as well. It's much drier, and you don't tend to see so many bloody fluids unless it's a different, some breeds, it'll be bloody all the way through. And finally, late estrus. This is a typical image of when we carry out late AIs when using frozen thawed semen. And as you can appreciate, it's highly crenulated, dehydrated, very pale, cobblestone sort of effect, and you can see the lumen very clearly, and this is what you use to follow the vagina all the way up eventually to the cervix. Okay. It's not clicking. How do I make? Right, so we'll then now enter into the paracervical area. And this starts with as you can see on here, the dorsal median fold. And this is a fold of tissue that emerges from the roof of the vagina, extends into the vaginal lumen, and that you have to go underneath with the TCI scope. And therefore it is an obstacle. It is anatomically divided into 3 different tubercles: the caudal tubercle, the middle tubercle, and the cranial tubercle. And then when you get right to the top, you can see here we have the cervical tubercle, which houses the cervical orifice or opening, and the cervical canal. And around it is the fornix, which is the blind end of the cranial vagina. And it's important to be able to identify this because you do not ever want to be perforating it and ending up in the peritoneum. And finally, one sort of anatomical landmark that you can sometimes see is the transverse fold here, which forms between the cervical tubercle and the cranial tubercle of the dorsal median fold. So now I'll just show some endoscopic images of those anatomical features. And this is the start of the dorsal median fold. So you've just come through the caudal vagina, and then you hit the dorsal median fold, which is here. And as you can see, it's a very narrow lumen underneath it because it descends down into the vaginal lumen. And this is what your TCI has to pass underneath. And here's another image of that crescent here as well. And this is a endoscopic video, which will show you the start of the dorsal median fold. Again, you can see the crescent here, and it's a narrow lumen underneath. Here's the dorsal median fold, here's your lumen, and here's the catheter, just poking at where you need to go, which is underneath here. Okay. And then finally, once you get underneath the dorsal median fold, you come to the cervical tubercle, which you can see here in this image. It's actually a little bit pink in this image, but it's nice and smooth and round. And you can see here in this image, the cervical tubercle is in the distance, and this is the cranial tubercle of the dorsal median fold. And in between the two, you can't see it here, but would be the transverse fold. It's important to recognize these anatomical features in this image because it's quite easy to think that this is the opening of the cervix and try and catheterize it. And now we have a video which shows the catheter passing under the dorsal median fold. Here's the cranial tubercle of the dorsal median fold, and here we go is a cervical tubercle. And this is what I meant by here. It looks like this is the opening of the cervix, but it's not. It's just the dorsal, the transverse band between the cranial tubercle and the cervical tubercle. Okay. And finally, the fornix, which is really important to identify in these two videos. Important to notice that the fornix is the smooth wall of the vagina, and it's what you will go around when it's where the cervical tubercle is nestled into. In this image here, in the second video, you'll see it a bit more clearly. This lovely smooth wall, the catheter, and then that's the end here. This is the far end of the fornix, and this is where you do not want to be perforating with a scope. It would be very difficult to do it with a catheter, but if the bitch sat down or jumped at this point, you could easily perforate, and that's why restraint is so important, which we're going to discuss then too. But here is all these smooth walls. This really helps with orientation while you're moving around the cervical tubercle and trying to find your cervical opening. And finally, the cervical canal. This is the bane of our life while we're doing TCI. And the most important aspect about the cervical canal is its angle. And it's directed craniodorsally from the cranial vagina up the cervical canal into the uterus. And it's very important that our scope, which we're going to discuss in quite a lot of detail, that your scope and your catheter all have to be lined up to be able to catheterize and feed this cervical canal and getting the angles right. This is second image here. It's just an image of inside the cervical canal. You shouldn't be going in there, and I've just put it up here. You can see how red and smooth it is. It's best to stay out of there, and this is what it looks like, so you know if you get in there that it's time to back out a little bit. So the anatomical obstacles that we've just gone through that we need to identify and navigate. This is actually a summary that Dr. Wilson put together in her thesis, and it still stands today. However, some of these obstacles are a lot less challenging now with the new, longer, thinner Storr scope. So start with the length of the vagina being very, very long. The second one, the narrow space on a dorsal median fold with the old scope used to be a real challenge, and bitches found very uncomfortable. Now, most bitches, they're not sedated and they don't even notice. The limited space around the paracervical area in which you need to work to find the cervical os. And then position the ventrally facing mobile cervical os can be quite difficult. You need to go, we're going to show you how you go underneath it and turn it up so you can see the opening. And then again, as I said, the angle and the diameter in some species of the in some breeds of the cervical canal. Right, so that's the end of the first section, involving mostly the anatomy that we have to overcome and the obstacles that we have to overcome with TCI. Does anyone have any questions?
Yeah, we have one question and a comment that I would like to add. You did mention that TCI was developed way back in 1980. that one hurt a little.
I'm sorry.
Just get that one out there. Now on to more academic matters. This question was raised. The anatomy of the region of the paracervical area and the cervical tubercle seems quite complex. What's the best way to gain confidence with these landmarks?
Yes, that's a really good question. And hopefully by the end of this talk, we're going to show a lot more videos of that area, and seeing it in motion, I think you'll get a much better idea. But as I said, the fornix with a smooth wall lets you know the outside parameters. And then the cervix itself, we're going to show a lot more images of it, and particularly when you see the front of it with its furrows and the cervical os, I think you very easy, they call it often a rosette, you'll be able to recognize that. So we have many, many more videos coming and images that I think you'll start to feel comfortable with that paracervical area.
Sounds like we're all in the right place. One more question just came in. Does the bitch always have to be standing during the procedure?
Yes. Simple answer, yes. People did try to do it in an anesthetized bitch lying down. It's difficult in an anesthetized bitch because everything collapses. In an awake bitch lying down, it is difficult to manipulate. Yeah, it's not something either Dr. Burns and I would ever try and do or have had to do. All bitches stand. I haven't sedated a bitch now in probably 7 years. They all stand and tolerate it because they're in standing heat. And now as the new scope, they they really don't feel anything. So no discomfort anyway.
Let's see. Here's one more question. Can the identified scope, let's see, it just vanished on me, but it's back. Can the identified scope be used in bitches of all sizes?
Yes. I've inseminated everything from a 2 kilogram Chihuahua through to Great Danes.
Wonderful.
And that's the lovely thing about the new TCI Scope.
Sounds like we're all learning a ton. And so at this point, we'll turn the program back over, and I'm sure we'll have more questions at the next break. Thanks.
All right, great. I'll try to build on what we've done already with some tips and tricks. The other thing about that paracervical region too, that I would add is that insufflation sometimes helps, and I'll talk about that here in just a second. The first part that we'll talk about though is the equipment and basic requirements. I have this this picture up here. This one that I'm circling here is what I first used 20 years ago, and I just wanted to throw that up there and show how it's changed, at least for me over the years, and it's changed greatly, right? So that was the first setup where I had this giant Sony monitor and then a couple light sources, a xenon source and a halogen source. And then I did have this telecam, which was great, which is similar to this one. But now all of this really is contained here in this telepack, and that's what we use now. This telepack is really convenient and works really well for us. So this is the most up-to-date equipment that we use. And this is the scope. It's I think this is 43 centimeters. Fiona talked a little bit about the scope already, but it's this particular one that Storz made is a semi-rigid scope, and I believe it's got fibers in there, so it's just somewhat barely flexible compared to that old scope, which was glass in the center. And so the other one was much more rigid than this one. This one is just is what I would consider semi-rigid. I hope I have that right. And then we can insufflate as well. We'll talk about the shunt system here in a second also. And then the light source that they use is great, and the monitor and everything with this telepack is just works really well for us. So that's the basic requirements for to perform TCI. Again, the scopes have changed drastically over the years. This rigid cystourethral scope that we first used was much shorter. I think that was 20 some centimeters, maybe, compared to 43, and much more rigid. So this semi-rigid scope is much better for us. Here's the features of the different scopes, and that rigid cystourethral scope was a 30-degree offset. So it was a little bit different visualization. So it took me a little bit of time to figure out exactly to switch to the newer scope. Learning on the newer scope, I think, is pretty easy now. Again, that one was 29 centimeters, the first cystoscope. The new one's 43. That 29, there was some limitation with getting to much larger bitches, mastiff size, Irish Wolfhound size. They were a little more difficult to get all the way to their cervix. This 43 centimeter scope, the new one, is easy. We can get every breed. I haven't been able to not visualize any breed. The diameter is much smaller as well. And then the catheters that we use are on the next couple slides. We'll talk about catheters. First, the shunt system. This is the shunt is here, and that shunt is that goes past the vestibulovaginal junction into the vaginal vault and creates a seal. And so it almost creates a tie, but more importantly, it creates a seal so we can insufflate the vaginal vault slightly and see anatomy a little bit easier. I didn't learn, obviously, with this system, with this shunt system. So when it came about, it took me a while to get used to it. And now I use it on occasion. I don't use it. It just depends on the individual. This is the bulb syringe that we insufflate with, and then this is the scope all set up with the shunt system in place. Again, I use it on occasion, and I definitely use it when I'm teaching initially. The only downside really to this shunt system, it can cause a little bit of discomfort if you don't place the bulb just right past the vestibulovaginal junction into the vaginal vault. And then this O-ring, which is right here, can catch a little bit on the scope as you pass that through, because everything's sealed, and that can cause just a little bit of jerkiness to the procedure, and so it can stick just a little bit. I do lubricate it still, even when I use that O-ring in the shunt system, but it can still cause a little bit of, it can catch just a little bit. Like Fiona was talking about, you don't want to have any sudden movements with the scope, especially when you're up by the cervix near the fornix. Here are the catheters that we use. They are specifically designed for that scope. They're soft polypropylene. They do have a stylet, and the common sizes are 4 and 5 French. The stylet's tiny. Typically, we'll talk about this, but typically I use the stylet until I just enter the cervix, maybe 2 centimeters. They are marked in centimeter length, so there's a black mark on each centimeter, so you know exactly how far through the cervix you are. They're 56 centimeters, so you can typically, depending on the size of the bitch, pass it as far as you would like up into the, I pass it in through the cervix into the body of the uterus and deposit at that location. They do have a couple of ports out the side, not out the end. It does help reduce the backflow, and they are small. So they're, compared to the 8 French catheters that we used to use, they're either 4 or 5 French. So there's less dead space in the catheter. They are technically single use. There are some reports of reusing them after gas sterilization. Not recommended though by the manufacturer. So cleaning the scope is really important. Gold standard would be sterilizing it. It can be gas sterilized. It can also be steam sterilized. I believe when we talked to the manufacturer of the scope, they talked about potentially repeated steam sterilizing would shorten the lifespan of the scope. There is this cage that scope can go into and be wrapped and then sterilized. So a protective cage for the scope. Chemical sterilization with different products can be used following cleaning, the brushes, etc., and then air drying like any scope you would use. So that's kind of cleaning and sterilizing in between use is important. Okay, so for the setup, if your timing is appropriate, they should all stand with minimal restraint. And again, like Fiona said, that I don't think I've even sedated one in at least 10 or 15 years of performing TCI. I know I've done one in my life, and it's a long time ago. So if you have the appropriate timing, they should really stand appropriately. These are the setups that we're most familiar with. So I learned to do it on the floor with large dogs. I wouldn't necessarily recommend that. Getting up and down on the floor over the years hasn't been easy. So most of the dogs that we do are used to standing on tables, whether they're conformation dogs or service dogs, show dogs, etc. They're used to standing on tables, so they're happy to stand on tables. This is, I think this was modeled after Marion's first method. And there is a belly band here, because I'm guessing she probably did it, a lot of them by herself or with minimal help. So, and again, they do stand. So this door does open. They're happy to stand on the table. It does take minimal restraint. This is the setup that we have now with the telepack, and then we have multiple monitors so owners can actually see what we're doing. Hydraulic table is nice as well. And really having a stool and sitting behind them and having them be just the appropriate height, I think, especially when you're learning, is important because it can take longer and your arms will get tired doing that. So having just the right ergonomic setup, I think, is most appropriate. So to get started, lubing the scope is, I think, important to do that. And again, I do that whether we're using the shunt or not. I lube the scope. I don't lube the tip because I don't want to smear it on the tip and obstruct the view. I do wear gloves, and then warming the lube can be helpful, and the scope can be helpful as to make it a little bit nicer for them. So we do have them stand on the table. This is our setup. This is from New Zealand when Dr. Hollinshead had her setup there. So very similar. And again, this one you can tell she's happy to stand on the table. This is a dog that's used to standing on the table. We do put them on a few minutes ahead of time and let them relax and let them know that we're there. So we'll pet their hind end, we'll pet their legs, we'll let them know that we're behind them. We'll give them treats. We'll really give them a second to relax on the table before we start the process. And most of them, like I said, are really happy to stand on the table. There are different restraint methods that you can use. This is a rugby hold type method here. And then this one is holding underneath. Notice there's a little bit of pressure on the abdomen. A key is not to have too much pressure on the abdomen. We'll talk about that a little bit later. And when they do stand, they really are happy to stand. I think this one's getting treats at the time. And so if they come in, you know, even if they're in twice over a 6-month time or a year, they get used to coming in and knowing when they get on the table, they may get a treat too. So when they are in heat, they're really happy to stand on the table, and we try to make it a more pleasant experience for them. Okay, and then holding the scope. This is a most appropriate way to hold the scope. I'll show you some ways not to hold the scope in the next slide. This does take a little bit of time to figure out, because both of your hands have to work together to get either to manipulate the scope, to find the cervix, to pass the catheter through the cervix, and then to attach when you're doing a TCI, to go ahead and attach the syringe to the catheter and do all that. So that part takes a little bit of practice to do that. So you really need to be comfortable and balanced in your hand positioning. And the course that we teach doing this for TCI, we do go over this, and the participants get to practice that. So we try not to hold the scope down here on the camera or on the light source. I had a bad habit of holding it like too far forward for a long time. Gripping it too tight with too much of the palm, keeping it in your fingers, I think, is important because the manipulations are just really tiny. Once you put the scope in the vaginal vault, they're really small little manipulations that you're going to want to do with the scope, and you're going to want to be controlled with your movements as you're going in the vaginal vault with your scope. You're going to want to be really controlled. So again, it does take a lot of practice to manipulate the scope, find the cervix, and then catheterize the cervix successfully, and then infuse the semen. So it takes a little bit of practice. So that part was about the equipment, restraint, and then the scope handling. So I thought we'd pause there just for a second, and if there are any questions on that piece, and then we can move on to the next part we'll talk about is going to be going down to the cervix, navigating all of those impediments that Fiona talked about with the anatomy, and then Fiona will come back and talk about actually getting through the cervix. But any questions on equipment, restraint, or scope handling?
Yeah, there's several kind of related questions. That looks like the first one is, I struggle with the angle of view and focus on the new Urethra versus the cystoscope. I would like your comments on this learning curve.
Yeah, I struggled with that angle too. So that's that 30-degree offset that we were all used to with the older scope, and it went to about a 6-degree offset. So the orientation is different. It seems different, and I think for me it just took practice. So I got that scope was out, so I still used my old scope, the old cysto urethra scope, the rigid glass scope. I probably still used that for about 4 years, even having the newer scope, you know, because of that change, right? Because I learned on that old scope for so many years. But it is just keeping in mind, it is that offset that's throwing you off a little bit. And for me, the biggest thing that helped me was insufflating. And so once I was able to insufflate, and there is a little bit of an art to that because you can over insufflate. If you create too much of a seal, you can over insufflate. So just very, very gently using the bulb and insufflating it, I was able to get the orientation a little bit better with practice.
Okay, got a couple more questions coming in, so got some hot topics here. Regarding reuse of the catheter, how does CSU approach that? Is there a limit to the number of reuses?
Yeah, initially, so we have been able to clean the catheter and gas sterilize the catheter, and we will use it twice, a total of twice. So use it, gas sterilize it, use it again, a total of, yeah. So,
Okay.
so that's kind of what we do here. I wouldn't want them to get too brittle or rigid, because that seems, I think if you try to clean them and reuse them too many times, in my experience, they'll get too brittle and rigid.
Fogging of the scope, how do you reduce it?
Yep, and Dr. Hollinshead will talk about that a little bit at the end, and so there are some tips on that. If it's truly fogging, Fiona can talk about that, but if it's just mucus, so you can dab the mucosa a little bit, that's probably a universal endoscopy trick. I call it dabbing, I don't know what other people call it, but if you just dab the scope against the mucosa, you can usually clear mucus off of the scope. So that's the mucus piece, but Dr. Hollinshead will talk a little bit about fogging.
And then the others, I'm going to kind of put several together. They talked about the training program that you have mentioned. And so if I kind of morph these together, you mentioned a hands-on training course. Can you tell us more about that?
Yep. And so that's, and you'll have to help me with exactly the date, but that's going to be offered in September, I believe. I think September.
Right. I can take this one, but I had to look it up. So,
yep.
So yeah, both of these doctors are holding a TCI course September 16th and 17th.
Okay.
And then there's also a semen management and cryopreservation course the 2 days prior, I believe.
Yep.
You can access all that information at csuvetce.com. So I'll try to maybe put that in the chat somewhere. Anyhow, let's now go ahead and turn it over and have you guys continue, and we'll take some of the rest of these questions maybe at the last session.
Perfect. Okay, so we'll continue on. So the next piece that I'll talk about is going through those anatomical obstacles, and maybe I can give you a tip here or there with each one. So here's where we're headed, right? We're going to go through the vulva, over the pelvic brim, through the caudal folds of the vaginal vault, and then identify the dorsal median fold. And then we're going to follow that dorsal median fold to the cervical tubercle. Once we find that, then we're going to roll underneath the cervical, find the os, and then catheterize the os. So that's the basic idea of where we're headed. So I'll give you some tips here. This picture, this first one, this is a furry dog, right? So what I'm doing here is introducing the scope into the vulva, and I'm using my finger to do that. So I have my finger, or I have the scope on top of my finger that's just barely in the vulva. And so that's the easiest way for me to do that and introduce the scope into the vestibule that way. I don't introduce the scope, just the scope. It's too easy, I think, to get into the clitoral fossa because you really don't want to go there. You want to keep the scope dorsal, and having my finger as a guide in the vestibule is really the easiest way to do that for me. So, and notice the angle of the scope here. So this is a pretty dramatic angle. That's like 65 or 75 degrees, maybe more. So that's the scope. Here's a picture. Alternatively, there's the shunt you can use as well. We'll talk about that here in just a second. So here's the angle. So there again is a picture of the angle that we're introducing the scope. It's counterintuitive, right? Because you think you want to just put the scope in this way at 0 degrees. It's not like that. So it's 60 to 80 degrees or so into the vestibule. And then we're going to keep the scope somewhat dorsal so we avoid the urethra. And then as we go over the pelvic brim, then we're going to introduce the scope into the vaginal vault or into the lumen of the vagina. So again, this is the angle of introduction into the vestibule. That's the first key that I'll throw out there. Next key is we want to avoid the urethra. Here's a picture of the urethra anatomically. Here it is endoscopically. So I just want to show the mucosa here real quick. It looks like, I'm going to pause it here in just a second. Looks like that. So see how smooth and striated that is? That looks nothing like the vaginal vault. It looks nothing like the vestibule either. So that is urethra. That's what a urethra, endoscopic view of a urethra. So again, that's what that looks like. And see how much shinier that is. It's not folded. The striations are lengthwise. So that's what the urethra looks like. So we want to avoid that. The next thing we're going to do is go over the pelvic brim. So again, angle of introduction, and then we're going to move to about 30 to 45 degrees or so. So that's about at probably the urethral papilla vestibulovaginal junction. And then in this dog, she's not quite 0 degrees. She's probably 10 degrees. That's in the vaginal vault. And I know that that's a comfortable angle for her because I'm following the vaginal folds, the caudal vaginal folds, looking for her dorsal median folds. So I'll show you a picture of that caudal vaginal folds here. These are similar to what you saw before. So this is around ovulation day. That's what it looks like. This is a pretty prime time, and then a little bit later. So those are caudal vaginal folds, and we would be looking for the dorsal median fold at that point. And that's over the pelvic brim into the vaginal vault, past the vestibulovaginal junction into the lumen. This is insufflated nicely. So if you see, once you insufflate, then you can really see anatomy nicely. And I'll just mention that again, you can over insufflate, especially with the bulb. If you give a small dog one bulb full of that, or squeeze it too hard initially, you can over insufflate really easily. So go really, really slowly with insufflation. I just want to stress that. And at the course, we can practice that too. So here we are. Here's going to be some videos for the caudal vagina to the dorsal median fold. I'm not going to show this whole thing, but this is what it looks like. So we're going up over the brim. Okay, so now we're in the vaginal vault, and you can kind of see all the folds kind of collapsed, and we're going to head there. Insufflated at the very end. Let me show that again. That was great. Insufflated right there. So insufflated, and right there is a dorsal median fold, right? So that's the part that we're going to follow straight to the cervix. If I can, that's a really good view. So right there. So the lumen's headed that way. Dorsal median folds here. We're just past the caudal folds of the vaginal vault, and now that's one of our landmarks. We're going to follow that all the way to the cervix. Okay, direction of the cervix, direction of the vaginal vault that leads to the cervix can be different in each different bitch. So, and what that means is, so again, that first video that I show, or that first picture that I showed, about 10 degrees, right? So that's comfortable for her following the vaginal vault. if you look in some brachycephalic breeds like English bulldogs, you're actually headed ventrally, right? So you're headed down. Those dogs, by the way, do pool fluid because their vaginal vault is tipped from their rear end to their nose, right? They're kind of tipped that way anyway. I guess the whole dog's tipped that way. So that kind of makes sense. So it would make sense also that their vaginal vault is tipped downward. And then, so the cervix is down. So if you notice, Dr. Hollinshead, her hands are now up. So her elbows are up following that down. So that would be this particular bitch and her vaginal vault where it's headed. This is a really good picture of, so she's in kind of a C-shaped, right? And you'll notice that the scope is here and the scope is angled this way. And that's because her cervix is about right here. And then her body starts to turn this way. So she's headed this way. She's probably following that vaginal vault right to about here. They have that abdominal cervix, right? So she's going to follow that vaginal vault to about right here. And so she's here on the side because that dog isn't straight. And so we can do it that way, but when you're learning, especially, you want to have them straight because you don't want anything to impede your progress or look different, especially when you're learning. So have them straight when you're learning, but not standing square can be a problem. Okay, other things that can hinder us, right, from following that vaginal vault. One is fluid, and English bulldogs or brachycephalic dogs are notorious for that. So discharge can be a problem. Having the band on maybe too tight and putting too much pressure on their abdomen. So excessive restraint, see how that's pushed up? So basically that's just collapsing the vaginal vault. So that's not helpful, especially if we've tried to insufflate so we can really see. Now we're just collapsing everything. So that's not helpful. Sometimes too, even to this day, a full bladder or full colon can hinder us following the vaginal vault appropriately. So having that empty. So if I'm having a hard time, not as much these days, but I will have them go maybe urinate and see if they'll defecate and then have them come back in because it can make things look completely different in a positive way. Okay, dorsal median fold is a really good landmark that we're going to use. Once we get through the caudal folds in the vaginal vault, then we're going to look for that dorsal median fold. And that's going to lead us right to the cervix. So this video shows a few folds. So dorsal median fold right here. It's going to lead us to the transverse fold on the cervical tubercle right here. So dorsal median fold, cervix. Here we go again, dorsal median fold. Look how nice that is. Right to the left of it. So usually we don't follow right under it. We're right next to it. And then right there is the cervix. So that's the top of the cervix. That's not where the os is. That's that transverse fold. We're going to go underneath there. Dr. Hollinshead will show you exactly how to do that. And again, dorsal median fold right here. And we're going to be to the side of it and follow it all the way to the tubercle. So that's the idea. That's an excellent landmark to go right to the cervix. Once we get down there, we're going to go underneath the cervix. We're going to look for the os. There's dorsal median fold right there. That was a really nice view. Caudal folds kind of zipped by kind of quick. Dorsal median fold. Now we're going to go to the cervix. And then we're going to roll underneath the cervix. Rolling under the cervix. That was perfect. So here comes again. Caudal folds, dorsal median fold here coming up somewhere, right? Okay, dorsal median fold right here. Now we're to the left of it and following it right to the cervix. There's the cervix right there, and then rolling it. She's gonna go this way, right there, right there. Okay, so you get the idea. Dorsal median fold goes right to the cervix. And then we roll under the cervix. Sometimes they pant. Most of the time they don't, but sometimes they do. I find they usually pant after I catheterize the os, which is interesting. They kind of hold their breath maybe before. Okay, so that's the idea. Once you get to the os, the os is pretty characteristic when you see it. This is a really nice view. This is a catheter here. This is cervical os. Here's the cervix, and the catheter just barely entering right there. And they can be in different locations. I have a slide of that. They can be ventral facing. They can face the wall. Let's go to that slide now. That's this one. This one's important. So this is a caudo-ventral facing os, and this is tricky with dogs, right? So they can be ventral facing. They can be facing the wall on the left or the right. They're rarely just caudal facing, so we can just enter the cervix. And I think this was probably one of the things that when Marion was figuring this out is that she appreciated right off the bat is this cervix, and each bitch, they can be a little bit different location. And so when you see enough of them right away, you'll recognize the anatomy when you get down to the cervix, and you'll know typically where it is. Sometimes this one's insufflated nicely, so you can really see the cervix here, and the os is right here. So it would be up that way. And Fiona, she'll show you a couple techniques on how to manipulate that, so it's just easier to see and catheterize as well. So here's one. So see how she just rolled underneath that? So you can roll underneath it and take the catheter and kind of move that os just a little bit, move that cervix just a little bit into a more appropriate position. Because in that position, you cannot catheterize that. Everything's straight. The scope is straight, the catheter is straight. So if it's not a straight shot, this is a left turn. You cannot get in that. So Dr. Hollinshead, she'll show you how to roll underneath and catheterize that. Okay, any questions on going from the vestibule, over the vestibulovaginal junction, into the vaginal vault, dorsal median fold, down to the cervix? Any questions on that?
Well, I don't know about that, but there is a holdover of some questions here.
Okay.
Questions about where to acquire the shunt system.
That is Minitube, I think, has the shunt system. And again, practice with that shunt system is important because that's sealed. So creating that seal, you can over-insufflate. So just start very, very slowly, especially in small dogs, just a little bit at a time, and you'll just be amazed how much you can visualize when you insufflate just a bit.
So how does the insufflation work when you don't use the shunt?
Right, yeah. So in other species that we do this in, there is no shunt. That shunt is specifically made for dogs. So when we perform this in other species, you can close the port on your scope, insufflate, and you will get just a bit of insufflation for a few seconds. So until that air evacuates out the vulva. So you can insufflate just a little bit as you go, and part those folds and really get an idea on where you are. You can't really over insufflate them unless you've created that seal with the shunt. So if you squeeze the bulb and you're in without the shunt system, it will give you a few seconds of visualization.
Okay. And then maybe the last one for this break, and then we'll pick up a few others at the end, but can the Minitube shunt system be used with the Storz scope?
Yep. And that is specifically, I think they designed that together. The catheters and the shunt system is designed for that Storz scope. So Minitube designed that, especially, I think, with Storz to have that system all in one. I hope I'm saying that right. To do that. So those were designed to be used together. Yep.
Okay. All right. I'll turn the program back over to you, and we'll see if we can pick up a few questions at the end, hopefully.
Right, we go to the last part, which is the final bit, which is finding and catheterizing the cervical os or the cervical opening. And there's two main aims to doing this. first bit we're going to discuss is finding the opening by rolling ventrally underneath the cervical tubercle and lifting the Oz up to be lined up directly in front of the scope. That's the first part. Then the second part is that angle. We need to get the angle of the scope and the catheter to be in line with that dorsocranial angle of the cervical canal. So there's two parts I'm going to discuss. So it's all about arms. So basically to roll underneath, to find the Oz and roll underneath it, you need to put your arms up and at exactly the opposite to what you did when Dr. Burns showed you when you entered the vulva. We're going to be 40 to 60 degrees up above the horizontal plane and roll underneath the scope, underneath the cervical tubercle. And this is what I'm doing here. Deflation. My scope is 40 to 60 degrees up and I'm rolling underneath. So that's what it looks like outside. And this is what it looks like inside. So there we go, rolling underneath. So someone asked about the anatomy. You can see the smooth Fornix wall and then the lovely rosette. In the middle of the rosette is the opening of the Oz. So again, rolling, using my catheter to roll underneath the cervical tubercle. There's the start of the rosette. In the middle of the rosette is the opening and you line it all up, ready for catheterization. Perfect. And this is another one over here. Same again, just with the newest scope. And catheter, again, that Fornix rolling around, that was on the roof, rolling all the way underneath, ventrally underneath the cervical tubercle, and there's the rosette, and then lining up for catheterization. We'll talk about the catheterization bit in a minute. Okay. So that's how we find the Oz with the arms up. Then the next difficult part is, and about catheterization, is that angle. It's all about getting the angle right. So it is basically getting your scope, getting the, as you can see in this image here, your scope and the catheter all lined up so it can drive up through the cervical canal in a craniodorsal direction. Okay. And the way in which you do that is the opposite. So to obtain the correct angle for catheterizing the cervix, you need to drop the scope down, almost like you were the position you're in when you're entering the vulva at 40 to 60 degrees below the horizontal. And then you use your catheter, the rigidity of the endoscope, and even a bit of air sufflation to sort of hold the cervical tubercle in position, line up, and then feed the catheter into the Oz and up the cranial, up the canal. This is one of the advantages of the new scope. It's much easier to physically manipulate the position of the cervical tubercle. It really does help with catheterization. The lower angle view, I know talking about with Dr. Burns earlier, not that 30 degree, but that much lower, a few degrees, means getting the TCI scope and positioning it face on is much, much easier. And that also helps catheterization as well. In some really difficult cases, you can insert the narrow tip of your endoscope into the external Oz to help catheterize as well. But I don't do that very often. It's only in very difficult cases. As you can see here, here's an image of my scope very low, 40 to 60 degrees below, and lining up to pass the catheter. And just before I show you how I do that endoscopically, I'm just going to mention twirling. This is one of Marion's favorite things that she taught me. It's a final technique, but twirling can really just help manipulate the Oz into the right position and get everything lined up, and also then help the passage of your catheter up the cervical canal. There are folds in the cervical canal, and there's definitely endometrial folds that you can get caught on. Twirling can help pass them, backing out, and then and going forward can also help as well. So it's a very, very handy technique, and this is an endoscopic view of twirling. Twirling the catheter into the Oz and helping for passage. And in this one too, I think we move it, we use the twirling to help move the cervical Oz into the position to get the angle right as well, so that we can then pass the catheter all the way up. Like so. Wasn't an easy one. Okay. So, as Dr. Burns mentions as well, if you go straight at the cervical opening, at cervical tubercle will basically get pushed away and the catheter will basically slip to the floor. You have to have everything lined up. This is a really critical picture. And this is an endoscopic view of not getting your angles lined up. You get to the cervix, just a minute. There we go. You just saw the os. There's the fornix, a nice small, smooth part. And then we're going to see the furrows, the rosette, and there's your opening. And you can see how the catheter is driving from up above and trying to catheterize the os, which is facing the opposite direction. And then it just slips out to the floor. That cervix and the os needs to be tipped upwards and lined up. So what you would do is drop your arms down. You could even elevate using, I always use a hydraulic stand, so elevate the bitch a bit as well. Dropping your scope down are two important ways to help try and get that angle right. Yep. Okay, so in summary, for successful catheterization of the cervix, you need to locate the ventrally facing os by rolling underneath the cervical tubercle, and that's with your arms up. You then manipulate the cervix so that the os is in line with and directly in front of the scope, using the scope and catheter together, especially with the new scope. And as I mentioned, a little bit of air sufflation helps lift things as well. You then drop your arms down and the scope down below the horizontal plane so you get that angle right, so that everything's lined up, your scope and the angle of the cervical canal, and you can pass the catheter up. If you're having difficulties, twirling can sometimes help get the position right and pass the catheter up the cervical canal. Don't ever use force. It's all about getting the angles right. So this is one of my silly pictures where I summarize where my arms are, and whenever I'm teaching my residents, I drive them nuts with arms up, arms down. So when you start, when you're entering the vulval lips, you have your scope down and you part the vulval lips and go up over the pelvic brim. Once over the pelvic brim, you move horizontally, but as Dr. Burns mentioned, depending on the bitch breed, you can be horizontal, slightly tipped up, slightly tipped down. They're all a bit different, but you're following the lumen and that's all that matters. Then you get to the cervix, arms go up to roll underneath the cervical tubercle. And then finally, you're under the cervical tubercle, you drop your arms back down so that you can then catheterize the os and the opening and run the catheter up the cervical canal. So I just briefly go over some limiting factors or problems with TCI. Most TCIs are actually really straightforward. And once you get the experience, you have a few under your belt, we generally do them in less than 5 minutes. There are some 10% that require more manipulation, that are just a bit more difficult to get that position of the cervix and the angles all lined up. And as Dr. Burns mentioned, always know when to take a break. Don't push yourself or the bitch. Give the bitch a break. And if they go to the toilet, and often urinating can really make a big difference on where everything is positioned. There are a few breeds that we've now learned are quite difficult to catheterize. The Bernese Mountain Dog and the Golden Retriever, surprisingly, can be the ones that you just can't catheterize. It doesn't happen very often. I think there's been about 1 in 500 bitches haven't been able to catheterize in the last couple of years. So some limiting factors or problems. Poor visibility is the main issue. And someone asked about fogging, and this is a classic example of fogging. We saw fogging a lot more with the older scope with the sheath on it. With the new scope, and as Dr. Burns mentioned, tapping the vaginal, the wall of the vagina is usually all you need to do to clear it. Don't try and pull the scope back out and wipe it, because it'll just bog again. It sounds silly, but in hot, humid places, if a dog is panting and really overheated, that actually can exacerbate fogging as well. So having a nice cool room is really, and a quiet room is really important. Excess bloody fluid and pooling, we've seen lots of images in this lecture of that, and again, they're mostly your brachycephalic dogs. What this can be solved sometimes, I've actually put a catheter in and sucked out the fluid so I can see the fold, so I can see the lumen, and even so I can see the cervix. In one bulldog, I sucked out 50 mils of estrus fluid. It was gross, but I could catheterize her. And then thick discharge, this can occur as well, particularly when you're doing late AIs, you get this sort of diastral dumping appearance. It's important in both these situations. This is not infection at all. It's no need to put on antibiotics. It's just a sloughing sort of late thick discharge. And it's not associated with endometritis. Okay. Safety is always important to mention. I think we've said it a few times now. Trauma can occur not so much with a catheter, but with that scope, and that is from poor restraint, a bitch that sits down or jumps unexpectedly. Could you perforate the vagina? Infection, this is more of a discussion. there's no greater risk of a pyometra compared to any other natural mating, a vaginal AI or surgical AI, or even in an older bitch not being AI'd at all. So we all know in estrus, the cervix is open, normal flora from the vagina will go into the uterus. In bitches that have cystic endometrial hyperplasia, it's not easy for her to clear the bacteria that naturally gets up there. And if she's AI'd, it's not that easy to clear the dead sperm and the egg yolk and things. And therefore they're at more risk of developing endometritis and pyometra. But it's not about the scope. As long as you clean your scope properly and don't introduce a primary pathogen, then it's not a greater risk. And finally, the last slide, I just want to talk about some other uses with the TCI scope. Obviously, we use it extensively for vaginoscopy, even prior to breeding, during, and using vaginoscopy during the heat. And particularly in pre-breeding, it's really important to pick up these, as I said, mentioned in the start, developmental, congenital, and even heritable disorders such as this beautiful septum here. And these obviously, you can get past them for an AI, but you do need to discuss whelping and heritability. Uterine biopsy can be carried out, particularly with these nice biopsy forceps. And Dr. Schlafer and Dr. Christensen wrote a nice paper about this, where they biopsied infertility cases, where there are sites of fibrosis, CEH, and abnormal structures. Uterine cytology was practiced a lot in the early 2000s when we were discovering and diagnosing endometritis, particularly the French group and the Australian group. And they used a specialized swab to do this. The only problem was, to diagnose endometritis, you need to put the swab into the uterus during diestrus, under progesterone. Because of the bitch's non-luteolytic mechanism, if you do that, you then have to give a luteolytic such as allicin or prostaglandin, so the bitch doesn't develop a pyometra. So it has its complications. And finally, treatment of pyometra, TCT, has been described by Dr. Verstegen and also Dr. Mason as a way similar to cattle, similar to mares mostly, of flushing the uterus, instilling antibiotics, instilling prostaglandins, and flushing the uterus of pus in pyometra cases. They have stated that they can clear a pyometra in 3 to 5 days, which is much shorter than medical treatment. I have not used this, and I do have my concerns about causing uterine rupture and peritonitis occurring also. So be very careful if considering this. And that's the end of our lecture. So if there's any questions, we'd be very happy. Dr. Burns will join me again too, and we can both answer any questions.
Well, it's very clear that this subject has resonated with our audience, because there's a number of good questions. We will no way be able to get to all of these, but I'm going to try to capture just a few of these. And then we'll refer others to your course. So you will be able to answer these questions and so many more. But the questions are, how many bitches you need to try until you get good? 50, 100, 200?
That's an excellent question. And with the old scope, it used to be 100. With the new scope, even after 20, you're feeling pretty proficient. What do you think, Dr. Burns?
I think that's right. Yeah, I did hundreds, I think, before with the old scope, before I felt confident. But yeah, 20 or 30, I think you'll be much more confident. And especially if you're, with insufflating, if you need to, it's much nicer and quicker.
I'll combine another couple questions. How many mils of semen is needed to insert, and how fast is it injected?
Great question. I'll tell you how we do it. And so there are a couple papers and tons of opinions and a couple papers. So I like 2 to 4 mils total. I think that's, for me, the most appropriate dose. And then depending on how nicely she's standing when we have her catheterized, I tend to infuse slower, I think, than Fiona on occasion. So I'll do it over several minutes, right? Even 5 to 10 minutes if she's just standing there, which a lot of them are. So I'll do several minutes. Sometimes I think if I instill or if I infuse too quickly, I'll get reflex back. So yeah, backflow. So that's kind of what I do. Fiona, You're the
No,
same.
no, I think that's good advice, and it depends on the breed. Obviously, with in a large breed, you can fit 5 mils if you slowly put it, but most standard is 2 to 3 mils. So yeah.
Very good. Well, I do want to be respectful of people's time. So for those of you who want to learn answers to these questions and so many more, we have these courses that are coming up. And so I had written them down and now that has disappeared from me, but they are in September. We have our cryopreservation and management of canine semen course. That is September 14th and 15th. And then the TCI course, the subject of this evening's webinar, is on September 16th and 17th. And so it's very clear there's lots of critical hands-on skills, and I'm sure that that will be valuable there. I think there's going to be more information in our trailer that runs after we shut down this show. So I want to thank Dr. Hollinshead and Burns for your presentation. We appreciate your willingness to contribute to Endoscopy Talks program. Once again, I'd like to thank all of you in the audience for joining us. In 2 weeks, we'll learn about portable endoscopy and zoological medicine given by Dr. Paolo Martelli, the chief veterinarian at Ocean Park, Hong Kong. That session will take place on Wednesday, May 19th at 8 p.m. New York time. And boy, did the sun just hit me in the eyes. We look forward to seeing you then. And in the meantime, wishing you all the best of health.
Hi, I'm Greg Burns, a theriogenologist in the Small Animal Reproduction Department at Colorado State University. I'm here at the Translational Medicine Institute to invite you to attend 2 unique continuing education courses. The first is cryopreservation and management of canine semen. This is a 2-day course that offers lecture and hands-on laboratory opportunities. Topics include semen collection, semen handling, and evaluation techniques, semen preparation and freezing, post-thaw evaluation, and proper storage for semen handling, and then also storage requirements for frozen semen. It's taught by veterinary specialists, reproductive physiologists, and andrologists. So if you're new to canine semen freezing and thinking about adding it to your reproductive practice, or you have experience and would like to improve your techniques, this course is for you. The second course is Introduction to Canine Breeding and Transcervical Insemination. I was in private practice for many years before pursuing board certification, and I know how difficult it is to learn TCI on your own. This is also a 2-day course. It includes lecture and hands-on laboratory opportunity. You'll be able to learn and practice TCI with an experienced instructor by your side. Other topics for this course include ovulation timing by vaginal cytology, progesterone testing, and vaginoscopy, as well as basic introduction to semen handling for TCI. Our goal is to instill the knowledge and confidence in each participant so they can start offering TCI in their own clinical practice. Both courses are offered at the Translational Medicine Institute. This state-of-the-art facility is located on the south campus of Colorado State University in the foothills of the Rocky Mountains. For more information or to register for these 2 courses, go to csuvetce.com. Hope to see you there.